So welcome everybody to the Bioethics Centre seminar. Thank you for joining us at this unusual time for those of us in England, perhaps. But we have two Australian speakers and a speaker from Wales. We're talking about assisted dying, and as there's quite a lot to get through, I won't say very much. So I want to introduce our first speaker, who is the Right Honourable Robert Clark, who is the former Attorney General of Victoria in Australia, the state of Victoria, and he participated in the Victorian parliamentary debate on assisted dying. So in the state of Victoria, assisted dying was made legal, and he's going to discuss both the Victorian and more general Australian experience and also his impressions of the UK Leadbeater Bill. So the Leadbeater Bill, the assisted dying bill, here is currently at the committee stage, and it's one of the reasons we're chairing this morning. So without further ado, I'd like to welcome the Honourable Robert Clark.
Well, thanks, Anthony, for your kind introduction, and it's good to be able to join this seminar, and hopefully we can all have a productive discussion. I gather the experience in Australia generally, and including Victoria in particular, has been cited by some supporters of assisted suicide as a shining example of how well it's all working. And I think one of my roles this morning is to disabuse anyone of that view, but also to talk about some of the lessons that I believe can be drawn from the Victorian experience about the problems that are likely to arise in England and Wales if assisted suicide were to be legalised. Some of you may know the Victorian assisted suicide regime, which is referred to in Victoria as voluntary assisted dying, or VAD, was legalised by legislation. It was passed in 2017, and as Anthony referred to, I was one of the MPs actively involved in opposing it. Regardless of anything you may have heard that might have been trying to persuade you that it was a wonderful process that led up to the bill, in fact, it was quite the reverse, basically a facade towards a predetermined result. It was a process that was driven by our Premier of the day as an item of, as a government initiative, and pushed through with all the force that a government can bring to bear on legislation. I can spend a lot more time talking about the woeful process, but I think it'd be more productive this morning to talk about the experiences since it's been introduced. But if anybody wants more detail about the process, you could have a look at an article that I wrote for the Australian online edition of the Spectator magazine that was published in December 2017, entitled "Making Victoria's Euthanasia Laws a Process to be Shunned." It's a little bit about the Victorian legislation's structure. It's broadly similar to the Leadbeater Bill. Two doctors are involved in the assessment. There's a submission of an application to proceed. The review, approvals given, the lethal substance is dispensed, usually for self-administration. It can be administered by the doctor if the patient can't administer it themselves. Probably the main procedural difference from the Leadbeater Bill is that the approval giver in Victoria is public servants, i.e. civil servants, rather than approval being given through the High Court. But otherwise, the broad structure is the same in terms of how the process operates. If you look at the oversight and accountability regime around the Victorian scheme, I've summed it up as saying it's basically hear no evil, see no evil, speak no evil. In other words, it seems very consciously designed so that the regulator will find out nothing, investigate nothing, and report nothing that could suggest that assisted dying is anything other than an unblemished success. So the approvals are granted almost exclusively on the submitted paperwork. There's no audits of what actually happens and whether or not it's compliant. There's no requirement for anybody involved to report adverse events such as bad experiences with the lethal substance. There are no rights for concerned parties to contest the giving of a approval. So it's a very limited accountability and disclosure regime, but even within that, there are some important conclusions that can be drawn. First of all, provision has been concentrated with a small number of practitioners. On the latest regulator's annual report, the 10 doctors in Victoria with the highest VAD caseload coordinated or consulted on 55% of all VAD cases in Victoria. So you could scale that up for the UK, but it's a very heavy concentration. Secondly, assisted suicide's been institutionalised throughout the Victorian hospital system. I'll say a bit more about that. Thirdly, as I've touched on, the regulatory focus is on reviewing the paperwork and ensuring the records are in order. So approvals are done on the paperwork. The regulators mainly look at the paperwork to make sure it's been in order rather than any investigations of whether what has actually happened behind the paperwork has complied with the legislation. There's a pretty bland range of data published. Things not published include data on the reasons for patients seeking VAD, the specialities experience of the doctors who are actually handling the VAD cases, times that elapsed between permits being issued and patients actually dying. In the early days of the regime, there were a small number of permit applications not granted, but no information's been published about why they weren't granted. Concerningly, in the last 2 years, there have been 0 applications for permits which were not granted. And you may say, well, that shows wonderful 100% practitioner compliance. But when you look at the regulator's latest annual report, it's clear the reason for that is that the public servants work with the submitting doctors to make sure that the paperwork is in order before it is submitted to the secretary of the relevant department to give the approval. So it's no wonder they get 100% compliance. There's no evidence that VAD in Victoria has achieved a reduction in the general level of suicide. There are a lot of claims made that VAD was necessary to avoid painful non-medical suicide, but the data on which that claim was, those claims were originally based, which was data produced by Victoria's Coroner's Court, has later been very heavily qualified by the Coroner's Court itself, and I can go into that if anybody wants me to. Victoria, as I understand, is the case in England and Wales, has serious shortfalls in the availability of palliative care. The best palliative care is very good, but it's often difficult for people to get palliative care. At the time of the legislation, it was estimated that there were around 10,000 patients a year in Victoria dying in avoidable pain due to the absence of adequate palliative care, and there's little evidence that that's changed since then. To me, that's an absolute outrage that any governmental regime could offer people a way to early death, but while not offering them a way to have their pain relieved. And in my speeches in the Parliament, I gave a number of very striking examples of people, particularly in rural and regional Victoria, who'd been left in appalling pain because they couldn't get proper palliative care and they hadn't been properly advised in the first place. The institutionalisation of VAD in Victoria has gone to the extent that the government is given far greater priority through the health bureaucracy to implementing assisted suicide than extending the availability of palliative care. And the iconic example I've cited often of that is that they've introduced a statewide service for the delivery to the home of lethal substances for assisted suicide, but they haven't introduced a similar delivery to the home service for people who are in need of pain relieving medicine. In other words, if you want assisted suicide, you'll get first class service. If you want palliative care, you have to take your chances with what you can get. The institutionalisation of VAD that I touched on earlier has had a very serious impact on doctors and other health professionals whose work involves end-of-life care. The government and the health bureaucracy have pushed the rollout of VAD across all public hospitals that may have terminally ill patients and have been very hostile to practitioners who've raised concerns not only about VAD in general, but even about the way particular instances of VAD are being handled in their hospitals, to the point where a number of practitioners have either left the state, given up practice, or have had to bite their tongue whenever they speak out, despite having been strong opponents of VAD at the time. Again, as I've referred to earlier, there's been a high concentration of the provision of VAD with a small number of doctors, and they seem to be the doctors who have a predisposition to supporting VAD and are therefore a high risk of being blind to what palliative care could do if it were made available to patients, and probably blind to the risk of lack of capacity, treatable depression, or subtle coercion. And on top of that, there's of course a risk that some will push the envelope and be prepared to disregard legislative requirements. We've seen that in other areas of practice. There's no reason to expect it wouldn't occur and with VAD. One of the consequences of legalisation of VAD has been a lot of patients now raise the issue of VAD with their doctors, which in one sense you'd say is great, but the trouble is that it has the risk that family and friends will unconsciously see VAD as the easiest way forward to resolve their own distress and their feelings of helplessness. And of course, it also creates scope for the subtle steering of patients' views by offspring who might have ulterior motives. And needless to say, elder abuse is as serious a problem in Victoria as it probably is in the UK. So what are the takeouts that I can see for England and Wales? Having given it a lot of thought, I think the single most important takeout is the inherent and systemic effects that the introduction of assisted suicide would have, regardless of what safeguards, regardless of what structure, and it's based around effectively the power and knowledge imbalance between practitioners and patients, and the risk that patients will end up making inferior decisions because they haven't been properly informed, and importantly, they haven't been properly reassured that the fears they may hold are in fact unfounded. The systemic effects not just going to affect those who might lack capacity or be suffering from mental illness or being coerced. It's basically everyone, other than perhaps a handful of those who are well educated, well informed and fully researched and know what they want to do. In every other field of consumer service, regulators, parliaments recognise that imbalance and the need to protect consumers. We do it in banking, we do it in financial services advice. It needs to be done by a parliament in relation to assisted suicide as well, and recognise that it's the vulnerable, the disadvantaged, the less well informed, those who've been brought up to believe that doctor knows best, who are most vulnerable and most dependent on how their conversation with the doctor goes. And I mean, the problems are, first of all, that I think legalising assisted suicide will send the message that it's simply a factual matter about, do you take this option or do you take that option? And it's going to deter the recognition of patient vulnerability and the need for reassurance and emotional support by the professionals of the doctors who are advising them. If UK is anything like Victoria, a lot of doctors will not have good knowledge of what palliative care options are available and what can be achieved by good specialist palliative care. So even if they're doing their best, there's a serious risk they'll misadvise their patients. And as I've touched on, the concentration of delivery of assisted suicide in the hands of practitioners who've got a personal emotional commitment to it is likely to leave them blind to the problems, as well as shaping attitudes of family and friends. And whatever safeguards you have aren't going to help, because the misadvised patient won't recognise that what they're deciding is not necessarily the best course available, and the misadvising doctors will be oblivious to that as well. So very quickly, what does this imply, or what would I conclusions would I draw that might be relevant, particular for the Leadbeater Bill? Clearly, the first takeout is don't pass the legislation, but going beyond that, and if we are contemplating the awful possibility that it might be passed in one shape or form or other. In terms of amendments, one of the big things to recognise is that a whole lot of safeguards that might seem good in concept aren't going to be much good if their application and review is by those who are committed to assisted suicide, because almost all the safeguards can be distorted and got around if people want to. I suppose two possible exceptions to that are a prohibition on practitioners initiating discussion about assisted suicide. I didn't think that was going to make a lot of difference because word spreads by word of mouth, but the feedback I'm getting is that if a practitioner initiates the discussion, the patient will often take it as an implicit practitioner endorsement or recommendation, and therefore those who want to be guided by their doctor will take the wrong cue from it. So that could be a worthwhile safeguard. I think the other important one is to make sure that institutions as well as individual practitioners can't be compelled to be involved with assisted suicide. I think that's important so that practitioners who have reservations about assisted suicide aren't driven out of that field of practice altogether, and also so that it can be safe havens for those patients who just don't want to be exposed to any subtle pressure to take assisted suicide, and who want to be supported by carers who don't have assisted suicide on their agenda. Beyond that, I'll just briefly mention in broad terms 4 areas of possible amendment that I think would be important. First of all, to ensure that whoever does the regulation of the process should be a generalised regulator, not a specialist regulator. If you have a specialist regulator like the Victorian Voluntary Assisted Dying Review Board, it'll be staffed by those who are supportive of VAD, and they won't be impartial regulators. I don't know enough about the powers or operations of the Chief Medical Officer in UK to comment in more detail. I think if they are the regulator, 1, you want to give them the powers that they need. 2, you want to make sure that the staff who are doing the regulation aren't specialist assisted suicide supporters, but are more generalist regulators. Secondly, regulation needs to look at what actually happens in practice, not just on the paperwork. Thirdly, whoever the approval grantor is, the High Court under the bill, there needs to be a way for them to receive inputs and factual information other than from the treating, the 2 doctors involved and the patient. There needs to be opportunity for the patient's regular GP, if that's someone different, or family members or social workers, to tell the decision maker, the approval giver, about what's actually going on. It's in that diversity of viewpoint that the approval giver can be properly informed and not just go on what's being fed to them by the sort of ex parte applicants who want approval. And the final recommendation would be to make sure that the widest possible range of data is collected and published, so that down the track people can see how the regime is working for better or for worse. I give you a long list of possibilities, but I'll leave it at that for the moment. So I hope those overall remarks have been of some assistance, both about how the Victorian regime has actually turned out as distinct from what its proponents say it's doing, and secondly about what insights can be drawn out of it for the Leadbeater Bill and for possible amendments. I'll be very happy, of course, to take things further in Q&A, or if people want to email me for any further information offline, my email address is robert@robertclarke.com.au. So thanks very much, Anthony.
Thank you very much indeed. Well, yes, we'll have a Q&A after our 3rd speaker, Professor Taubert. But now we're staying in Australia, and our 2nd speaker is Dr. Greg Pike, who is a Senior Fellow of the Bioethics Centre itself, and he's also the founding director of the Adelaide Centre, and he is going to speak also about assisted dying in Australia and lessons from there. Greg. Oh, could you unmute?
There we go. Everyone hear me all right?
Thank you.
All good. Thank you. Thanks, Anthony. Pleasure to be able to share in this. I'm going to focus mainly on the research that's been done in Australia. I'll come to that shortly, but I did want to just say a few comments about the board reports. So basically the evidence base we have comes from 2 primary sources. One, the board reports, and the other research done by a body of researchers. A couple of particular things I want to pick up that come from the board reports. If you have a general statement about the board reports, is that it's sort of straining gnats, swallowing camels. So the really big and significant issues to do with safety are not in the board reports, and you won't find them there. This is to reiterate what Robert was saying. But what you will find is a lot of information which I think gives a bit of a screening effect and keeps things from proper scrutiny. But I want to highlight a couple of things, and it's a difference between WA and Victoria. And in Victoria, not only that question of whether doctors can raise the matter of VAD, but also that if someone's unable to self-administer, then they can have a practitioner administration. Now, in Victoria, that means that when it gets down to it, it's about 85% choose practitioner or go to practitioner. Sorry, 85% are self-administration, and about 15% are practitioner administration. So in other words, euthanasia is the small bit, assisted suicide is the big bit. I'll come back to that in just a moment, but in WA, the numbers are the other way around. Now, the WA board report itself suggests that part of the reason for that is the question of doctors raising the issue, which they can do in WA. And maybe because they can raise the issue in WA, then that stimulates people into accessing VAD. Incidentally, the numbers are roughly double overall in WA compared with Victoria. So a lot more is happening in WA, and a lot of it is euthanasia, not assisted suicide. But there's just one other thing which could be involved here, that in Victoria, it's only if a person is unable to self-administer that they can receive practitioner administration. Whereas in WA, it's whether they have concern over self-administration. It's not whether, no judgment call is made about whether they can or cannot self-administer, but if they have enough concern about self-administration, then they can receive practitioner administration. And perhaps that is more, or may well be more, the reason. Now, how does this relate to the UK? Well, there's just one possible way that it does, that in the UK, the question of assistance, I think, is rubbery. It's really not made clear what degree of assistance a doctor can provide. And when it gets down to the event itself, some of those assistances are going to look very much like administration by a practitioner. And there's no real check and balance to know precisely what happens during that encounter, to be sure. But when in the UK, there's another question arises, which sort of happens here. It's the what we don't know question. So back to Victoria for a moment. In Victoria, we've got most by self-administration. Someone receives the VAD substance. They are then able to take that at the time of their choice. So that could happen months, possibly up to a year later. So if we look in the board reports, we will find that there's a certain number of substances delivered and a certain number of deaths, which is quite a bit less than the substances delivered. Some substances have returned, but we know virtually nothing about the actual moment at which that person takes it. Who was present? Was there coercion? Was there capacity retained at that point of use? We don't know any of that. How does that relate to the UK? Well, it doesn't directly, because in the UK legislation, bill, a doctor has to be present, but not necessarily in the room. Now, that gives enough of an out for a practitioner to be sitting out in the car outside, or another room, or if it's a hospital, where in the hospital. I just think that's a really unclear question that leaves open the circumstances of the actual death largely unknown. So if there was some amendment that would tighten that up, I can understand the reason behind the drafters of legislating wanting privacy for the family and so on, but it's too important, and a doctor should be present. So I'll shift now, leave the board reports for a moment, other than to say that if you were to read one of the board reports, you'd be a convert pretty quick, because it's full of emotive accounts of how wonderful the whole thing is, how we badly need doctors, how there are too many safeguards. The WA report says that they've got research collaborations going, and most of it's to do with gaining more practitioners and reducing barriers to access. And I think this is one of the points really related to what Robert was saying at the start, is that once this business gets underway, and I must admit to being a bit taken aback by this, it's not just the passage of legislation. It's the setting up of a massive bureaucracy. It's a massive bureaucracy that swings into action, and suddenly you've got enormous amounts of funding. You've got your VAD coordinators in the hospitals. You've got a Queensland voluntary assisted dying body to look after people. You've got navigator services. You've got WA's remote access service. You've got a whole range of things to make it as accessible as possible and as easy as possible. Incidentally, the WA board report does say that practitioners, and this is the concern of the board, who are previously engaged are turning away. I find that an interesting observation straight away. But to the research itself, I'm really uncomfortable with the idea of sort of bagging where research comes from, but I'm going to make an exception here, because nearly all of the research on this issue comes out of the Australian Centre for Health Law Research at the Queensland University of Technology. And researchers there, the reason I would make the exception is that there are 4 issues of concern related to the work of that group. First of all, they're long-time advocates for VAD, and they have been working in this field and advocating, not as researchers, but in other capacities, for a long time. So there's that history. They were involved in the Australia 21 roundtable back in 2013, which was about as stacked as you could get. So there's the long-time advocacy. The centre itself currently provides information of direct assistance for people to access VAD. Now, this is a research institution, so direct assistance for people to access, and also they are publishing non-research related documentation about overturning what's called the telehealth ban. So in Australia, we have a federal piece of legislation, which means you can't counsel or aid or abet suicide in any way over electronic carriage service. And that's seen by a lot of advocates as a huge barrier to access, and they wish furiously to overturn that. So this group is advocating for that. Third, they wrote the model legislation. They wrote the model legislation, which was picked up by Queensland. And so there's a strong investment, I suppose, in their work. And finally, they provide and conduct the VAD training for practitioners in several of the states. And I presume that's a paid service. I don't know. But that, I think, sets up a significant sort of background of conflict of interest that people should be aware of, because about 80% that I can find of the research on VAD in Australia comes out of this group, particularly 2 researchers. When the research that they have conducted itself is not sort of unusual in methodology. It uses what's called purposive sampling, followed by snowball sampling, though. And what that means is that the researchers get to select who's going to be surveyed as part of their research. So it's wide open to bias. Now, the difficulty here is that I'm going to work off the presumption that they're honest researchers, but the methodology chosen is such that we can't be sure that there's not a significant selection bias in the work. Most of the work relates to interviewing and surveying VAD practitioners, VAD families and caregivers, and the VAD families and caregivers are accessed through Dying with Dignity. That's quite open. They're open about that in their papers. They access through Dying with Dignity who most people would know is a strong advocacy organisation. But probably even the bigger advocacy organisation in Australia is Go Gentle Australia. And that's the other group that they access. So if you're doing purposive sampling and drawing from those two sources, you can select, or you will be put to you who those bodies think are the best persons for your research. And then snowball will happen, and you ask those people who they think should then be part of the research. And that's how recruitment happens. And that's deeply problematic in a controversial area such as this. Most of the research, is conducted in a survey of patients, caregivers. Sorry, not there's one patient. It's mostly caregiver or doctors. Some of the views of doctors were nuanced, but the authors of the paper in question conclude their papers by saying the newly regulated practice of VAD into the profession of medicine should become the immediate goal for government agencies and health services. Right? Despite those nuanced views from the VAD practitioners. Then a common conclusion in many of the papers is that there are way too many barriers to access. And I think this is what happens when you get something established within the context of health. It becomes healthcare. You have the bureaucracy which builds up with it, and then you very quickly find that it has to be treated in an equitable way, just as any other health issue is supposed to be, but often not. And so there's all this impetus and this effort to increase access and to make sure that you can recruit more doctors. Robert's already alluded to the problem with very few doctors involved. In WA, there were 5 who undertook 43% of all first assessments, just 5. So, and then of course, you can have nurses undertaking first assessments now in the ACT. And of course, nurses can be practitioner administering as well. In the last a couple of minutes, I'd like to suggest that in keeping with that idea of straining gnats and swallowing camels, that here, some of the camels, the big questions of safety, which remain unanswered and unresearched, and no one in the business seems to have a lot of interest in, except there are a couple of papers, there are a few, relate to, as I'll run through some things, as Robert highlighted, the proper reasons why people choose. Now in WA, there's the only state where you find any information on the reasons why people have chosen. But unfortunately, the question asked is, are you concerned, do you have pain, or are you concerned about pain? Those two are lumped together. So you can't distinguish between an actuality and a fear of it. So that's the pinnacle of our data on why people choose. There's a case before the Queensland coroner at the moment about diversion. A man died after taking the substance that was authorised for his wife. So the wife died of natural causes of her condition, and then he took the substance. So that was a case of diversion. That's one that's come before the Queensland coroner. But I would say, given the circumstances, it's back to Victoria for a moment, where self-administration is most of the cases, and we don't know what goes on there in that room when that happens, the risk of diversion is real. Because, it's very easy to, one scenario might be that the person actually, over a period of, gets the substance, several months later, dies of natural causes, and the person who's the contact person, because you have to appoint a contact person, then says that the person took the substance and died, because there's no coronial inquiry. Says the person took the substance, but then diverts it for another use. And I think if you're dealing with complicated grief, and that's a whole question in its own, complicated PTSD, which is cited by some psychiatrists as a real risk, not unlike the complicated grief which occurs post-abortion. But I think the point is that we're missing out on a lot of information, a lot of data The other thing which we get from places like Holland and Belgium is the tracking through time of things like death without explicit request. Okay, so a person, non-voluntary euthanasia. The Dutch won't call it that, the Belgians won't call it that, but that's what it is. So death without an explicit request, or intensified alleviation of pain, in other words, opiate overdose, or CDS, continuous deep sedation, slow euthanasia, effectively, an intention to end life, withdraw food and fluids and deeply sedate so the person never comes to. We know a fair bit about those practices in those countries. If we were serious in Australia about finding about the impact of VAD, we would be seriously looking at those things and see whether they change, just as we should be looking at the incidence of unassisted suicides and how that might be changing. And I think there's a paper by David Jones about that, showing the increase in unassisted suicide. So look, I think I'll leave it at that point because I'm outstripping my time, but thank you.
Great. Well, thank you very much indeed, Greg. And I'm sure we'll be coming back to those issues in the Q&A. So our final speaker is Professor Mark Taubert. He's a hospital consultant and clinical director at Velindre University NHS Trust. He's also associated with the School of Medicine at the University of Cardiff. And he is going to speak from a palliative care perspective. He's the founder of porkcpr.com and chairs the National Future Care Planning Strategy Group for NHS Wales Executive, and is the Vice President of the European Association for Palliative Care. So without further ado, Professor Taubert.
Thank you, Anthony. That's great. Greg and Robert, thank you so much, and I'm glad you outstripped your time because I've been furiously taking notes because I'm very interested in the international situation. I live and work here in Wales, in the United Kingdom, where I'm principally a clinician, a palliative care clinician, and I work in the hospitals and the hospice settings. I got an honorary professor title a few years ago. I think the university took pity on me because one of my main topics is do not attempt cardiopulmonary resuscitation, and I'm national lead on that topic. So I take a lot of flack in that very controversial area as well. It is a little bit of that experience and my daily experience with patients in the hospital and hospice setting, which turned me very skeptical towards assisted dying and assisted suicide a number of years ago. I would say as a medical student, I was pro, and then through years of practice, I developed more and more concerns, and I wanted to talk a little bit about the Leadbeater Bill today, but also about my own experience. And it's very interesting hearing from internationally. And I've been following the situation in Germany, my old home country, a lot as well. You'll be interested to hear that in Germany, assisted dying was practiced until 2015, and then the Bundestag, the German parliament, actually banned it because the practice was expanding without particular safeguards. There was a huge expansion in practice. Doubling of numbers year on year, and it was very unregulated. So the Bundestag, with a quite significant majority, decided to make it illegal from 2015 to 2020. And then the Supreme Court in Germany overturned that ban in 2020 as unconstitutional. So again, you have assisted dying as a legal entity in Germany, and numbers are going up. And I recently facilitated a discussion with my friend and colleague, Professor Lukas Radbruch from Germany, who said you can really see year on year the numbers are going up. Supply is creating demand, and but general suicide rates are going up as well. So I've been following that situation with some interest as well. And I'm looking forward to the discussion afterwards as well, where we can maybe compare facts and figures a little bit. But I thought the data from Victoria and from WBA was very interesting there as well. I'm actually on BBC Radio 4 tomorrow morning, very possibly. I'm not sure what they're going to ask me, but some of this data might come in very handy. So as I said, I'm a clinician who works in hospital, hospices, and community settings sometimes as well. I have a Thursday palliative care outpatient clinic. I've now had patients in that clinic for over 10 years under my service, and it's also not uncommon for me nowadays to discharge my palliative patients. So that's really changed over the last years. So often when people think about palliative care, they often think about the last days and weeks of life, but we are now often involved from diagnosis onward, and that's been a big shift in the last 10 to 15 years. Even in advanced cancer, which is often cited as the biggest example when people want to push forward assisted dying legislation, even then I've seen prognoses vary hugely, including in some of my younger patients who I typically see for many years. And I'm aware that people with life-limiting illness frequently have periods of vulnerability, severe depression, and fragility in those times as well. So it is a concern of mine that legislation for assisted dying in the current context of very fragmented, inequitable, and poor care will lead to people opting for an assisted death because they cannot access the care they need. They hear reports about corridor care in the United Kingdom at the moment, which is a huge strain on the NHS services. And choice for some, I think, will become a societal order, really, or duty, who have been made to feel a burden throughout their lives. And you know, by that I mean some of the patients I see tell me that even, you know, healthcare staff that they've overheard in sort of conversations on the wards, for instance, say they hear healthcare staff say things like, "I couldn't live like that. How can she live like that?" And of course, those things can sometimes push you further. Since the assisted dying bill was voted on in November for the third reading, second reading to third reading, and the committee stage, the requests in my service from patients, but also from relatives for assisted suicide have gone up significantly. So my staff and I have heard far more requests from people. So because this is being discussed so openly, we've had a number of relatives say, "Well, couldn't you hasten my sister or my mother's death because you wouldn't treat a dog like that?" So that's the usual terminology that is used. I mean, and for me, the framing of terminally ill adults with a prognosis of less than 6 months, I see both cancer and non-cancer patients, and I feel a lot of this debate has focused, as so often, on stage 4 cancer. This year alone, I've seen several patients with diagnostic labels in their notes of end-stage chronic kidney disease, end-stage lung conditions like chronic obstructive pulmonary disease, end-stage cardiac failure, and end-stage Parkinson's disease. You know, on the elderly care psych wards that I cover in Llandoch Hospital, I've seen many patients with the end-stage irreversible dementia label on their clinic letters. And you do wonder what the definitions of terminal illness with less than 6 months to live means, and how it can be interpreted. Just recently, I saw a lady with end-stage bronchiectasis, a lung condition, and she'd had that in her notes for the last 15 years. And the respiratory consultant who referred her to me laughed and said, "Yeah, I've known her for the last 15 years, and that's what we've had in her notes for the last 15 years. I didn't think she would do this well during that period of time." Of course, during that time, she's had severe episodes of depression, fatigue, has felt awful at times. And so the label of 6 months or less with a terminal illness would have definitely applied to her 15 years ago. And given her at times fragile mental health, she would likely have availed of an assisted suicide service. But I know I've seen her, and she's gone back home again since I've seen her, and you know, there are plenty of moments of happiness and fulfillment where she can spend time with family as well. And I think that would not have been the case had an assisted suicide clinic been available to her 15 years ago. Things have changed significantly since I was a medical student. A patient with cystic fibrosis in our area has recently celebrated her 83rd birthday. I mean, this was unheard of. When I was a medical student, you learned that these people don't live beyond 20 years. And so I think I heard just this morning on BBC Radio 4 an oncologist who's very pro-assisted dying talk about the cancer trajectories as we know them. Now, Scott Murray, who works is a professor up in Edinburgh, has said that some of the trajectories that we've used in palliative and end-of-life care are probably not fit for purpose anymore, because you get a different subset of people now who are benefiting from the latest novel treatments that are really completely changing the outlook with some of these things, and actually making a 6-month prognosis very, very difficult. And a big one for me, and I've written in the Spectator about this as well, is that there's a big assumption that these assisted deaths will always happen smoothly, and involve just taking a few tablets at home, perhaps surrounded by family. And I think the public deserve to know in advance what this process involves. And I've been really trying to look very hard for some really good, accurate data on A, what medication regimens are being used, and B, what the complication rates are. You get data from Oregon. Again, it's very limited data. I think only a very small percentage of their data is actually published. A lot of the other deaths happen behind closed doors, and you just don't know what is happening. Some deaths can take over 100 hours, and complications can arise to what I feel is a body that is not quite ready yet. So such deaths would likely need to take place in a clinical setting with access to, say, anti-seizure medications, equipment to help in case of severe choking, air hunger during that process. I think the process may involve large volumes of different medications, and processes such as having the anti-sickness medication first, then a sedative 15 minutes later, and then the lethal medications. I've been interested in hearing about the use of pancuronium in Australia, and I don't know what the experiences is there, but I know that pancuronium and such medications aren't sedatives. So when do you apply the sedative? How do you ensure that the sedative effect is actually working, so that you don't run the risk of a person being quite conscious when the inevitable shutdown of the musculature happens, because your entire musculature is essentially shut down, including your breathing musculature, when you receive curare type drugs. So these are some of the things that have not at all been laid out in the Leadbeater Bill. There's no detail in it at all. I was surprised that a 40-page bill was published, when I think, had I, been tasked with something like that, I think it would probably have been more like 400 pages, and all the different aspects of it would have been thought about. There was mention by MPs about, well, Mark, it could be not oral medications, but syringe drivers. Well, syringe drivers in the UK are usually given as a subcutaneous infusion, in my experience. And I think that would exclude some substances, including barbiturates like phenobarbital, which can actually cause severe necrosis of the skin if you give it subcutaneously. So intravenous, usage would have to be used and guaranteed. And following on from that point, I think these assisted suicide services would function in clinical surroundings. Would they have to involve the use of on-call anesthetists, for instance? And would we have to make use of on-call services if these deaths are happening and are longer than expected? I'd be interested to hear what happens in Australia if such deaths are prolonged, and is there an on-call system where the healthcare practitioner who's been asked to stay or asked to administer this notices that the patient isn't dying? What happens then? Is there a protocol to give more medications or not? And in the UK, we're not talking about euthanasia. We're just talking about assistance in the act of suicide. Of course, if a patient is in a semi-conscious state after ingesting the lethal substance, they're not able to take any more. So what do you do then? You know, if these deaths take over 100 hours and go into a bank holiday weekend, is there some sort of on-call rota? It's really difficult to know. Data from several countries suggests that there's no medication regimens that are actually consistent. Everyone seems to be using something different. Oregon uses digoxin, amitriptyline, morphine, and a diazepam combination. So those 4 drugs in combination together with antiemetics. And complications can arise from that. Switzerland and Germany use pentobarbital, approximately 20 grams, and parts of Australia seem to be using curare type drugs like pancuronium. We heard from an oncologist this morning on Radio 4 citing the New Zealand data, saying that they had published a 300 to 400 page report, and that report suggested that in the last 3 years of introducing assisted dying, there hadn't really been any problems. And he actually labeled this report as a systematic review. Well, in my experience as a researcher, because I also do some research alongside my clinical practice, that doesn't sound like a systematic review. That, again, similar to what Robert Clark was mentioning at the start of this, sounds more like self-reported data that is published. So looking at several countries so far, no medication regimens have been licensed for the purpose of assisted deaths. Many countries follow very different protocols with virtually no evidence base for any of these regimens. Just because death is a primary endpoint here does not mean we can be less scrutinous in applying evidence-based medicine, in my view. And I've written an article in The Spectator, which I can post in the chat a little bit later on that topic. So that's really all I was going to say, because I'm quite interested in the post-talk debate as well, and learning some more. And I hope that's been useful. I could talk about this topic for about 3 or 4 hours, and as many of you can, I think, but interested to hear from others as well and to learn something. Thank you.
Well, thank you very much indeed. That's extremely informative, and thank you to all our speakers. So I'm going to throw it open now, so you can try and keep sort of questions fairly brisk, but you can direct it to any one of the 3 speakers or all of them. And you can either write a question in the chat if you prefer to do it that way. And Mark's very kindly just put the article up there, so please do look at that. Or you can raise your hand sort of physically or electronically, and I'll try and get round to you. So if there's anybody who would like to begin, just let me know. I've got one in the chat. I presume that's for you, Mark, but any of you can come in. It's, have you any advice? So I didn't quite get the key messaging to the public based on your experiences. I'll assume that's for Mark Taubert.
Yeah, I mean, key areas for me really are around. For England and Wales at the moment, be skeptical about the 6th month or less prognostic label. Do not assume that doctors are particularly good at predicting that. In fact, all the evidence points in the direction that they are not very good at predicting that at all. And actually, some people suggest that the 6 month or less label is actually quite challengeable and potentially quite discriminatory as well. So I say that one of the key messages is it's quite easy for pressure groups like Dignity in Dying to push through a law on this, what seems a very sort of reasonable argument of 6 months or less with a terminal illness. Come on, you must agree that is very reasonable. But it's a very flimsy label. It doesn't stand up the test of evidence base. It's not very robust, and it could be challenged pretty much immediately in the courts. And where the courts have challenged laws in the UK, Parliament has nearly always caved. So that's a key one. I don't know if anyone else wanted to come in with some key messaging point from the previous speakers.
Sure,
Anthony, I
Robert
might
or
offer,
Greg?
look,
Yeah.
let me offer a comment from an ex-politician's point of view. I think I would suggest two proactive front foot arguments resonate with the public. First of all, the absence of adequate palliative care. It's very patchy availability. The outrage of the authorities offering you a way to kill yourself, but not offering you enough palliative care. We shouldn't be having this debate while there are these shortages of palliative care. The rich will be able to, the well-educated and those with good connections will be able to get themselves looked after. But if you're an ordinary member of the public, you'll take your chances. You might be lucky with a first-class practitioner. You might not. And as I touched on, there are some horrible examples in Victoria of people being sent home without proper pain relief and turning up weeks later at a public hospital in terrible pain, and people being left on the waiting list, not able to get access to palliative care, and in terrible pain in the meantime, etc. So the absence of palliative care, the general issue for the public, are you more worried about being over-serviced within the health system or under-serviced? The service gaps, the need to cover those first before you start talking about offering people death instead of proper care. And the second, to me, argument is the one I touched on in my remarks: the need to protect consumers against sort of the power imbalance and being sort of dependent on doctors and being swayed by doctors. Again, you can contrast those who are well-informed, well-educated, strong-willed, etc., with the ordinary person who's been brought up to believe that doctor knows best, is frightened, lonely, desperate, in pain, and looks to their doctor for every cue or nuance. And you need to ensure that people who are that vulnerable, that part of the duty of a professional is to not just tell them the facts and let them make up their own mind, but give them sound professional guidance and advice. And they won't get that in an assisted suicide regime. One, because there'll be a whole bunch of practitioners who don't know enough about palliative care, but two, because they'll tend to be funneled towards those practitioners who think that assisted suicide is best, have a sort of a vested emotional and professional commitment to it, and therefore not likely to give them good advice and be blind to the risks. So that's how I would put it. You need to distill all that down to about a 10-second soundbite if you're speaking to TV or radio. But to me, those are the messages that are likely to resonate with your ordinary member of the public.
Yes, if I could add something to that, I think there's a significant portion of the population who would think carefully about the principled arguments. And what I mean by that is that, as we know, this is grounded in suffering. The Leadbeater Bill has an explicit statement about symptom relief being irrelevant. So if someone does have symptom relief, that's not something that disqualifies them. So what that effectively means is that physical pain is not the primary thing here. It's this broad notion of suffering, which has often got social, existential, psychological elements to it, which is the focus. If I think back 20 or so years, it was all about the sort of image that people had in their mind of the extreme and unbearable pain. You'd pick it up in movies and TV and so on. And that's what it was all about. So now we're in a quite different, it's subtly shifted over 20 odd years. So it's something utterly different now. And Leadbeater Bill effectively is saying, we'll use terminality as the framing for other forms of suffering. But if someone has a disability and is experiencing those same sorts of suffering, well, I'm sorry, you're not terminal. And this comes up in people's comments. They say, well, what? It's not fair. Why only terminal people get this when we're suffering just as much? So the principled argument would say, if we're talking about that sort of suffering, then we should be ready for what's coming next, which we see in elsewhere, and that is dementia, mental illness, in Holland and Belgium, minors and children. That's because it's an uncontainable notion of suffering. And I think there are people who may listen to that.
Great, thank you. Karen and Santa, have your hand up. You could just come in. Did you just unmute?
Thank you for this very high quality debate. So I'm very concerned about many aspects of this bill, but I'm a general practitioner, and what really another facet that is worrying me is that I don't know if you're aware, the speakers, but the British Medical Association is wanting to have doctors start the conversation about assisted suicide with their patient. So I'd like to know from the, Robert Clark and Greg, and also Professor Mark, experience in Australia, and also you mentioned, Professor Mark, that there's been an exponential rise in people coming to you whilst this bill has been in the media wanting assisted suicide. So I'm very concerned that it's going to change the dynamics of the doctor-patient relationship, and there will be doctors who will be probably quite, I don't know, there's not much time in general practice, and how are you going to have this sort of conversation, and if parts of Western Australia are trying to have things done by telemedicine, end of life conversations, I think it's very concerning.
Karen, where do you work? Are you in England?
In North London.
In North London, okay.
Yeah.
Fine. I mean, if I'm permitted to take that one first, I mean, I have a lot of advanced care planning discussions with my patients. I have a lot of do not attempt cardiopulmonary resuscitation discussions with my patients, and I'm in the front at the front line, and it also, sadly, because I have those conversations, also, of course, exposes me to more complaints, especially from relatives and others. And I think I hold those conversations quite well. I've had practice over the years, but the amount of times this is misinterpreted as meaning, oh, he's talking to me about CPR now, that means he thinks I'm going to die in the next few weeks, is huge. And you have to actually ask the patient what their thoughts are once you've had that discussion, for them to honestly come out with some of those statements. So for me, just from my experience, I know that there's going to be huge misunderstandability of when you're broaching this topic, interpretation of that meaning that life must be short. And as one of the previous speakers mentioned just now, a lot of my patients here in Wales also think clinician knows best. So if clinician even says the word assisted dying clinics exist, I understand what he means without saying it. He suggested that. They will go home, they'll discuss it around the dinner table, and because the option exists, it becomes, in their minds, perhaps a no-brainer to actually choose that option. So the mere existence of such a service then becomes a gateway into the service. Again, as my German colleague said, supply creates demand. And once people have heard that, their uncle here or there or relative has used these services, then it grows. And it's certainly grown year on year in Germany as well. I won't hog this. I'll let the other speakers also come in on that question.
Thank you.
In a way, we probably shouldn't be too surprised. People will have heard of the Werther effect for suicide in general, and how there's quite a bit of media advice about care with talking about suicides. So we know that suggestibility, as light touch as that might be in a media article, is sufficient to tip people over the edge. So why wouldn't we expect that there's a growth phenomenon and the supply creating demand type question with assisted suicides? In a way, it should be no surprise.
I can't add much. I think the exclusion of the ability of doctors to initiate in Victoria has avoided the problem that I touched on and that Mark elaborated on about people taking cues from their doctor. It is very risky, because it will, with the best will in the world, even if there is the best will in the world, it'll send the wrong signals at a time when patients are looking for guidance and reassurance at a time of great stress and uncertainty.
Thank you.
Great. There's a number of questions in the chat. I'll come to them in a second. First, David Odeberg has his hand up, and then we'll do the chat.
Thank you. I found this extremely interesting. Just to say, in terms of messaging and so on, when I spoke at a panel on this bill for a local MP, which I think was a kind of, it was almost like a rubber stamp exercise that he organised, pretending that there would be some debate, but actually he knew exactly how he was going to vote, and sure enough, he did vote in favour of the bill. But he had this kind of, Potemkin panel, which I went on. And as far as messaging goes, it was quite a large number of people attending, all of them, on the elderly side for obvious reasons. I insisted on calling it a euthanasia bill because Leadbeater has been very careful not to call this a euthanasia bill or an assisted suicide bill. She actually changed the name of the bill just recently. It was called something slightly different. Now it's been called the Terminally Ill Adults End of Life. But trying to make it as sound as anodyne as can be given the subject matter. But it's actually a euthanasia bill, and I kept calling it that. And I would urge everyone to call it. It is a euthanasia bill. I mean, you can predict if there's, and I'm not much of a gambler, but if I could gamble, I would place an extremely large bet that within, I don't know, maybe a couple of years, 3 years, however, after the introduction of this legislation, a test case will be brought before probably the High Court on Section 18. So Section 18 says, no obligation to provide it. That the patient must that the patient or the victim, must self-administer. And there's no duty created on the part of the medical practitioner to administer, any noxious substance, etc., etc. So what will happen, and you can take it to the bank, is that there will be a case of, let's say, someone who's paralyzed, say a quadriplegic, who can't self-administer, and then who takes it to court as a test case backed by all the usual people to demonstrate that actually the legislation has been badly drafted, that it couldn't have possibly have been the intent of Parliament not to allow administration by a medical practitioner in hard cases like this, that there would be a perverse result if someone was punished, in other words, prevented from euthanasia, because of their own misfortune, being quadriplegic, and everyone will have sympathy with that. Well, why are they not allowed to have what the other people have simply because they're quadriplegic, or that they're unable to self-administer, or because they have some other terrible disease, so mobility disease. So this will be euthanasia. So whether it's been drafted deliberately like that, I don't have any evidence, but I would suspect, based on years of reading about this sort of junk, basically, that this has been carefully crafted to ensure that a test case will come before the courts in a few years to make it a full-on euthanasia bill, and there will be amendments or secondary legislation, or it's just idiocy and they don't realize what the implications of the legislation are. So I think everyone should be calling this just a euthanasia bill, because that's what it is.
David, I think it's the former rather than the latter. I think they've been very clever. They've used PR agencies. They've had a lot of money. They've got quite good international funding as well. They're very well connected internationally as well. So Dignity in Dying UK are very connected with the international networks. In countries where assisted dying is legal, Dignity in Dying organizations really go for the law and coroners and various others who want to investigate cases, and can be quite aggressive in their approach. In saying that this shouldn't be investigated. It's disgusting that the police are getting involved because there's a fear of coercion in this case. It's a very well organized network of people. The Dignity in Dying used to be called the Euthanasia Society, and then they changed their name. I don't know when they changed their name to Dignity in Dying. Masterstroke. They now can claim that they own the sort of that they invented the concept of dignity in dying, and you can only have dignity in dying if you have one of these assisted medical deaths. And assisted dying itself as a terminology is also very clever. Assisted dying sounds quite benign. I mean, I would say as a sort of palliative care clinician, I work in assisted living and in assisted dying. That's my practice. I assist in the process of natural dying. But they've just bagged it as their term, because you are now shouted down in the UK if you use the term suicide for this. There was an MP in Parliament debating the Leadbeater Bill who said, it's disgusting that you say these are suicides, because these people are terminally ill in the last six months of their life. She had no idea that, in a sense, these are suicides, you know, by definition, if you look at the dictionary definition of what a suicide is.
In Australia, the latest, not state, one of our territories, has permitted euthanasia without the time frame. Okay, so it's already made that move to. So with regard to the terminology assisted dying, if there's no time frame, how does someone determine if someone's dying? Do you know what I mean? I was under the understanding that it was actually quite a rigorous task to determine what dying was in that last phase when someone is genuinely dying. But if we're going to allow 10, 15 years, as in the ACT, someone has what they personally believe to be intolerable suffering and fit the other criteria, it doesn't matter how long, then how can that be assisted dying? Isn't that just an odd term for something that can last, someone who's clearly not dying, and you're not assisting their dying, they can live for a long time.
Okay, I'm going to go to the chat. There's a number of comments. Mark has very kindly put up his Spectator article, which I strongly recommend. So there's my colleague is reminding everyone, which I'll do now, if you wish to donate to the Bioethics Centre, we run on a shoestring, and we're always very grateful for any help. So there's a link in the chat for that, or we can go to our website. Okay, so comment or question from David Mummery says, in Australia, are these experiences being acted on, and is there widespread concern about what is happening? So generally, in the last few years since this legislation in Australia, is there a concern, or is that tailed off? Maybe.
So you mean at the public level?
Yeah, that's what the question is.
Absolutely.
Had public concern increased or tailed off in Victoria?
Well, I think if the public are concerned, we haven't heard about it.
Okay.
Media are generally bored out on this, and so you're not going to hear much about concern.
Okay.
It's very hard to tell.
And two more questions on the Australian is, has there been published independent research reviewing carer or physician experience in Australia? So the effects on people who are involved carrying this out. And the second question is whether faith communities have been issuing guidelines about how best hospital chaplains could still support families in these situations without sort of cooperating with the assisted suicide. So sorry, there's two rather separate questions, but maybe if our Australian speakers and Mark, if you want to come in, would like to address them.
If I could just comment quickly on the research side of it. As I think I mentioned, the research on doctors is particular in style and selective in who it recruits, and the outcomes of those questions and surveys of those doctors is invariably that the safeguards are too much. We need to expand access. We need to come down on conscientious objection. So I think the fact that you're getting that view coming through those publications is really that you're dealing with a very specific group of bad practitioners, and you're not picking up the views of peripheral doctors or doctors who don't really like what they're seeing or have concerns. I just can't find research on that sort of thing. It's this very narrowly construed research.
Just to add on that, I suppose the fact that it is certainly in Victoria, and I gather from Greg in Western Australia, there's a heavy concentration of bad practice indicates a lot of practitioners just don't want to touch it. They sort of vote with their feet to walk away from it. There are figures published in Victoria about the numbers of doctors who've done the training to pre-qualify to be able to take part in the VAD process, and those also are a very small proportion of the number of practitioners. So you may draw the inference that a lot of doctors just are walking away from it. On the, or steering clear of it. On the second question about faith-based guidance, I'm not aware of anything relating to chaplains in particular. I do know in Victoria, a number of faith-based nursing homes are grappling with the issue of residents who want to access VAD and whether or not they are able to exclude that, or if they can't, how they handle it. And it's a very vexed question. It bears out what I was saying earlier, about the importance of making it clear that institutions can declare that they don't want to be involved with assisted suicide as well as individuals. And you can have an argument about a nursing home, whether it's simply a residential facility or not. I would have thought the important thing is for institutions to be able to declare their policy that basically we are a nursing home that doesn't take part in VAD, and that's the basis on which you come here. But I can't say anything specific about chaplains, I'm afraid.
Interesting. And I've been talking to a group of people that have been working on with some of my DNA CPR policy work called Muslim Doctors Cymru. So a useful Welsh group of Muslim doctors who have real concerns about the terminally ill adults Leadbeater Bill. You know, and I'm also very interested in the question of whether individuals will be able to conscientiously object and opt out of this, including the discussions around it, whether institutions will be able to do so as well. I mean, you know, in Birmingham, you may have some, you know, nursing homes that cater more to Muslim patients, and we have a Jewish nursing home, for instance, in Cardiff here as well. And you do sort of wonder where the faith-based institutions might be able to say, no, we wouldn't want this to happen on our premises, or we wouldn't want to be involved in this process or not. I think that must be an option, but I'm certainly not seeing any mention of it anywhere. What would be really fantastic, I mean, I'm just sort of hogging my speaker ability here at the moment, is to have some sort of evidence-based zone, some good evidence base, a rapid review of some of the evidence. What I'm finding is that the pro side often use big slogans, and they sometimes use quite flimsy, what they call research to found some of their arguments. Now, I'm someone who likes quite rigorous research. I still critically appraise the research articles that I read. It would be good to look at some of the claims. For instance, the claim that 20 people each day die in pain, in unrelieved pain in the United Kingdom. That was based on an OHE report that were doing some statistics using the 2015 Voices survey, then extrapolating the data to 2023 mortality data. So they did about 4 minutes of mathematics to write a 15-page report on the fact that 20 people a day die in unrelieved suffering. You know, I think a statistician could probably trash that quite quickly, because they extrapolated hospice patient data to the whole of England and Wales. And we all know that hospice patients are quite a specialist and select group. You know, it'd be fantastic to have an evidence-based centre that could actually sort of review some of the claims that are being currently made by the pro side. Sadly, not scrutinised by the media particularly.
Yes, that seems to be a general problem. Thank you. So, a question concerning on-call personnel cover. Are there any conscience or clause cover for medical personnel or other conscientious objectors in these bills at all? So, I'll start with the Australians and then talk about the Leadbeater Bill. It was discussed yesterday in the committee as well, I believe. So, Robert or Greg, on the Australian experience, what kind of provisions are there for conscientious objection, and how's that played out?
I have to look back at the detail of the bill. There are exemptions of the Act. There are exemptions in the Victorian Act, but as people would have gathered from what I said in my presentation, the reality has been vastly different from the the theory. Certainly in public hospitals, there's been a lot of pressure put on anybody who's got any objections to VAD. A lot of them have suffered professional pressure and difficulties. One of them, who was very senior palliative care practitioners, left the state because they couldn't stand what was going on here, and others has told me that they've got to be very, very careful about what they say these days because they still need to earn an income. I've heard reports of others who've been demoted and suffered other problems due to speaking up about concerns about how VAD's being applied in their hospital, etc. The very senior ones are able to tough it out, but for others, it's been very difficult indeed for those who practice in public hospitals.
If I could just comment, I can't recall specifically from the different pieces of legislation, but certainly a strategy which has been used is to require referral. So to say, yes, we're all in favour of conscientious objection, but if a doctor does have an objection, they are required in the legislation to refer to someone who does not have an objection. Now, in terms of the ethics, well, that's really just asking for participation, and it's not in keeping with that person's conscientious objection at all. But it's a sort of seen as an in-between strategy of ensuring this great goal of access for everybody.
And in terms of the on-call side of things, I'm aware that I think about 2% of the doctor workforce in Canada gets involved in assisted dying. That's not a huge amount if you think about the size of Canada. And I do wonder in terms of provision of things when they go wrong. So I suppose Canada, you have both the practice of assisting a suicide where a patient can take the lethal substance themselves, but you also have physician-administered euthanasia. And perhaps not surprisingly, most people opt for this safer option of physician-administered euthanasia. But I'm not sure, so that's not under discussion in the UK at the moment. It is this act of kind of suicide with a medical practitioner present. Now, if something were to go wrong, if it were prolonged death, like we've seen reports of in Oregon, over 100 hours or several days, how would that work? What setting would that be in? How ready would you be for adverse events like choking, delirium, air hunger, seizures? What's in the room so that you can actually manage those situations? And do you actually phone the out-of-hours GP or the on-call palliative care doctor for help when those complications arise? Now, I might have conscientiously objected out of the practice of assisted deaths and assisted suicides and euthanasia, but I would find it very difficult to withdraw my help if someone is dying from one of these deaths and is choking, for instance. I would want to give advice. I would want to help. Others may not be willing to do so. So I think that's something that we need to think about as well. The sort of as often with these things, private medicine and various other things, they sometimes rely quite heavily on the existing public services that are around, including on-call structures. And suddenly when everything goes wrong, everything comes to us again, So that's another aspect. And many GPs will agree with that.
I have a lot of sympathy for the position you'd be put in under those circumstances, because if someone were in the process with all of that substance in their system, wanting to die, and your impulse is to resuscitate with all the relatives there, it must be an appallingly difficult set of circumstances to imagine.
Yeah. That's why I'd love some really decent data from places like Australia and New Zealand, because I suspect these situations have happened, but the reports maybe haven't quite covered that in as much detail as we would hope for.
No detail at all. None.
In Victorian, probably
whatsoever. The only complications mentioned in the board reports are paperwork and return of unused product.
I mean, paperwork can be quite traumatic. I will say that, but
Sorry, Robert, you want to
just
say something?
yeah, I was just going to add to what Greg said. Yeah, there is a cone of silence about it. It's not generally known what medication is actually being, what substance is actually being used in Australia. In Victoria, I think it's our Alfred Hospital has got a specialist unit that prepares it, as I mentioned, delivers it through a statewide delivery service, but understandably they keep under wraps exactly what it is. There are issues with our Therapeutic Goods Administration, which is a nationally Commonwealth regulated body, about what substances are or are not permitted in Australia. There was a big concern about the illegal importation of Nembutal prior to legalisation of VAD. Whether that's now being used legally, I don't know. But in Victoria, the coroner is actually excluded from investigating any death once the legally authorised substance has been taken. So as I pointed out during the debate, someone could be finished off by being smothered with a pillow and no one would ever know about it. The coroner couldn't investigate. There's no obligation for adverse reporting. There need not be any practitioner present. So it is possible that people are dying very terrible deaths and it's not becoming known. I imagine if there are enough of those occurring, some friend or relative would speak up and it would become known. But we really just aren't aware of what's going on for the reasons that I've referred to.
yeah, I mean, the medical examiner service in the UK is very much there to kind of help with learning from deaths. You know, that's what we try and do, and there seems to be very little learning from assisted deaths because it's such a highly sensitive area that perhaps is fearful of criticism. Yet I know from attending deaths, including in the hospice and the community, these are highly stressful events, and people will be driven to do all sorts of things. And that's not just families and relatives, but also healthcare practitioners. You know, we've all heard about the case of the sarcopod and the strangulation marks in Switzerland. You know, no coroner investigating that would of course be an outrage. But yeah.
If I could have a quick comment about the drugs used. Worthington published a piece in 2022 in the British Medical Bulletin about drugs used in assisted dying, and he came up with 22 different drugs used for euthanasia and 17 for assisted suicide, but no consistency of use across the board. Now, my background originally was in physiology pharmacology, and if you use drugs at different concentrations, some unusual things can happen. So when there's no evidence-based data about massive doses, you can't be sure that it's just a magnification of the effect at lower dose, because you get some very unusual effects of drugs used at higher doses that can actually reverse what they would normally do.
Yeah.
So it's just bad science.
Bad science. And you know, in part, I think in the Netherlands, morphine was used for a while, and they quickly dropped that one because it's actually such an unreliable drug. You know, for those purposes. Often our palliative care patients have been on morphine for quite a number of weeks and months, and actually the sort of respiratory depressant effects are highly unreliable, and in very high doses can cause severe delirium side effects, but not always death. Quite distressing if you just pump in very, very high doses. Of course, Shipman did his bit to kind of make to perpetuate the morphine myth in the United Kingdom, but many of his patients didn't actually die. You know, so yeah, very, very complex topic.
Okay, I'm going to just go through several questions and people to pick what they like. So one of them is there evidence connecting coercive control, assisted suicide, and estate management? And so inheritance issues in the legislation, has that come to light? And then a separate question. Is there a place for a task force or group of clinicians and academics to design a robust evaluative tool for different stakeholder groups to try and get some funding, seed funding for a pilot to promote it, to sort of put stuff out there, what initiatives might be taken. And then third, so these are three separate questions. In Australia, were doctors consulted properly before the legislation was brought in? GP members of the Royal College of General Practitioners are being sent a survey. There are concerns about the wording and distribution. How protective is the conscientious objection clause? Do doctors or hospices suffer from hostility or coercion if they refuse from voluntary assisted dying? Bad. So, sorry, three rather separate questions there, but if any of you want to...
Should I do the estate management one first? So
sure.
I mean, evidence tricky, but sort of what I see is, I mean, I can tell you of several situations that I've seen where, you know, we've been made alert of coercion. I mean, when coercion is very obvious, you can spot a few of the red flags and it's easy to spot. When coercion is less obvious, us busy clinicians will not see it. We will not spot it. And I've had to sort of be alerted to it by some very clever social workers on occasion that there's been coercion going on. We had a lady in the hospital here for a little while who we wanted to discharge, and a relative of hers was saying, no, she can't come home, and had moved into her mother's house, you know, and wanted the chemotherapy to stop. All sorts of very, very sort of obvious. It became very obvious, and we discussed it in our MDT quite a lot, that this was going on. And even the mother was sort of aware of it, and the brother, but it you know, that's sort of the absolute tip of the iceberg where red flags are very clear, and I suspect we don't even spot 5% of it, you know. So that's one area. I mean, estate management and inheritance, it's quite interesting. In Germany, you get it's become such a business now that you can go, and as a couple, you can go to an assisted suicide service and say, well, we want to do this as a couple. And then you'll get a discount. So usually it's about 4,000 euros per assisted death. But as a couple, you get a discount and it only costs you 6,000 euros in total. So they do the paperwork, they do the bureaucracy, etc., etc. And then there's an interesting question to answer. Who's going to go first? So is it the husband or the wife? Because that is obviously important for the estate. And that's often where a bit of the bureaucracy then really kicks in to sort of work out with the lawyers. Is it better if so-and-so goes first or the other one goes first? You know, because the estate will fall to the one who lives longer, in a sense. And so you have to sort of time this quite carefully. So crazy the amount of sort of thinking that has to go into some of the legal and estate management side of things. I'm hearing that insurance companies are quite interested in this, but haven't got a huge issue with it. Perhaps insurance companies have sort of talked internationally. I've seen examples of how this works, and perhaps you know, finding the prospect of assisted dying something that they don't necessarily want to sort of go against necessarily, because you know, a lot of German health insurers perhaps have seen some of the cost of healthcare in the last year of life. So there's a big cost economic argument for this as well. I mean, the cost economic argument, if you read some articles in the Financial Times, is so compelling that you know, it is nearly impossible for a politician to ignore that, I would say.
Right. Okay, Robert or Greg, anything on the...
Well, not much to add on the coercive control and estate management. Yeah, as Mark says, I think it's very difficult to detect subtle coercion. Elder abuse figures are very high in Australia. I expect they're the same in the UK. And people can sort of just drop hints about, you know, the burden that caring for grandma is putting on the grandkids to make grandma feel, you know, it's about time, and the grandkids are suffering, and it's be very hard to detect that. That's why one of the reasons I think a broader range of inputs into the High Court or other approval process may help pick up some of that, if people can tell different aspects of the full picture. Were doctors properly consulted in Australia before VAD? Certainly not in Victoria. As I said at the outset, it was a charade process here, and a lot of doctors were very strongly opposed to it.
So one of the questions I was asking about Australia, but more generally, I think here as well, whether doctors were properly consulted before the legislation. What was the role? And they've mentioned that GP members of the RCGP here being sent a survey. Were most doctors in favour in the state of Victoria, or was it very divided amongst different?
I'm stretching my memory. Greg, you may know better. I think it was a divided profession, and a lot of the surveys are sort of voluntary replies anyway, so you can't be completely sure of what the true picture is.
The other thing is, I think it's like a lot of things that happen that are new like this. You get a bit of a balls rolling type effect, and people will feel like they'll try and, if they don't have particular convictions about an issue, they will move with where they sense the direction is heading. So not only do you not survey everyone properly, you get this sort of odd effect of the sort of swing vote on the issue, if you like. But beyond that, I think that there's something else that we should pick up from the evidence that does exist, that when you get significant vocal support for something like this, but then you find an extremely low participation rate and even lower willingness to operate in the later stages of the process, right down to minuscule amounts of people, you have to say, well, how reliable was that original survey work if people are simply not prepared to go anywhere near this? A very interesting paper came up talking about the numbers of doctors who participated in some of the training program, that 20-something% of those doctors that participated had a conscientious objection to VAT, and yet they did the training program. Now, I don't know what's going on there, but it's odd.
Yeah. Very odd.
So if there are any final questions, people put their hands up. Otherwise, we have to wrap up, or any final observations. I mean, at the moment, this bill is at the committee stage. In fact, as we speak, the committee is hearing evidence. It's very contentious about who's being called to give evidence, and there's some interesting exclusions, but that will be going on for the next few weeks.
The call for evidence is continuing, and you can email them. I might try and see if I can put the details in the chat, so anyone here who has issues with it can write up to 2,000 words, and also make multiple submissions as well. So if you have concerns, if you're a GP, for instance, who has concerns, anyone who has issues or concerns raised, going line by line through the bill, you can pick up one part of the bill and really focus on that if you want to, and actually give your own evidence, your own experience into it. This is a really unique opportunity. You won't have it for long, and I think they need to hear everything. I'm hearing they're being a bit overwhelmed, but I think we should, continue to do so. Oh, fantastic! Someone's actually put it in.
That's great. Great, yeah.
Yep.
Yes, no. So please do take note of that. We put our own submission in.
Yeah, I put an individual submission in, which slightly breached the 2,000 words, and I'm going to put another one in. So don't hesitate to put several things in and looking into it.
Right. Well, I'd just like to thank our three excellent speakers. Learned a great deal about a very difficult subject, and it's not going to go away anytime soon. And I think, I mean, one thing that strikes me is that in places where it does pass is the importance of trying to gather data. As you said, part of the problem is getting the data that can actually assess these. This kind of legislation is very difficult and requires very determined people like yourselves. So I'd like to thank everybody very much indeed. Thank you very much for coming. Please do check out the Bioethics Centre website, make a donation if you can, and I'm sure we'll be coming back to this topic in the future. So thank you all very much indeed, and speak soon. Thank you. Take care.
Thank you very
Thanks,
much.
Anthony.
Thanks for hosting us.
Thank you.
Thank you.
Thank you.